Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balata from Roots Community Health Center, reporting for the week of December 26, 2022, our final briefing of the year. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. This week, I'm going to start with respiratory illnesses other than COVID, followed by a COVID update and what we might expect next. Unfortunately, we have another pathogen to add to the list of concerns, and that is Group A Strep, the bacteria that causes strep throat, among other things. And last week, the CDC released this health advisory to warn us about a recent increase in pediatric invasive Group A streptococcal infections. So Strep A has already caused 2 child deaths in the United States, and the CDC is receiving reports of increases in invasive Group A strep in pediatric hospitals from several states, and so they are investigating those reports, and that's what this health advisory is about. I have to say that looking at the data sources, it does seem to me that some jurisdictions report in some ways, and there's other data collection that's happening that contributes to the CDC surveillance, but all in all, it doesn't look like there is a very cohesive reporting system from what I can tell. But having said that, in the United States, 2 children have died from invasive strep, and those were both in the state of Colorado. And children's hospitals in Colorado have been reporting higher numbers of invasive strep than usual this year. And the last death that they had was back in 2018. And other hospitals in other states like Arizona, Texas, and Washington are also seeing higher numbers of pediatric invasive Group A strep. Also in the UK, Strep A has caused at least 21 child deaths. So in the UK, they've already had 94 deaths across all the age groups. And this includes 21 children under 18 years old in England. Again, pretty unusual, and so that is why we just are having a heightened state of alert about this. So Group A strep is the bacteria that causes strep throat. It could also cause skin infections. It can cause infections of the blood or sepsis, which is what it can be the more severe condition that can lead to death. And it can cause some other pretty unpleasant skin type of infections. It also causes scarlet fever. So this basically starts with flu-like symptoms, a high fever, sore throat, and swollen lymph nodes in the neck, and then a rash 12 to 48 hours later. And this is like a small and bumpy kind of fine rash that starts on the torso, and then it spreads from there, and it can feel rough like sandpaper. So it's actually important to touch because you can't always necessarily see it, especially on darker skin tones. And so this is just something to be on the alert for. There's no reason for particular alarm, but it is a bit unusual. So I think we're going to be wanting to keep an eye on what is going on here. But certainly for a strep throat, you just want to check in with your medical provider, see if it needs to be swabbed and sent off for more testing. And if you have a child with symptoms or signs of scarlet fever, or definitely anything where they seem like they're sick and then it's persisting, it's not getting better. Sometimes it might seem like it got better and then it gets worse after that, or fever comes back. Those are all signs that maybe this bacterial infection may be present. And so something to check in with the doctor about. So we'll just mostly be keeping an eye on it, but wanted everyone to be aware that this is something that's kind of adding to the situation, particularly in certain states in the United States and in other parts of the world. In general, our activity for both RSV and flu are high, but they both seem to be coming down in most areas of the United States. So this is good news. Of course, it's different in different regions, and we'll need to keep monitoring, particularly flu, because we can see sometimes that it'll sort of come down and then go back up. And also with the holiday, we're not getting all of the reports, data reports super timely, but nonetheless, we see a little bit of early promising signs that these might be coming down, and hopefully it will just be, it'll just keep coming down and we won't have another rise this season. But as it relates to flu, we've had, unfortunately, the week ending December 17th, there were 17 influenza-associated pediatric deaths. And that was the highest that we've seen so far this season in 1 week. So that's a total of 47 pediatric flu deaths so far this season. And even 1 death of a child from a vaccine preventable illness is too many. This is something we should all seek to avoid. We have the flu vaccine for ages 6 months and up. So let's not have any more vaccine preventable deaths. And let's get our little ones vaccinated for all the things that they need to be vaccinated for, including flu. So far this season, there have been 190,000 hospitalizations from flu and 12,000 deaths from flu. And so the good news, though, is that all of our antiviral treatment for flu is working against the flu strains that are circulating. Our vaccine is very well matched to the strains that are circulating. So these are pieces of good news. I reviewed last week that we might be having a little bit of a shortage of the antivirals just because of the sheer amount of more moderate or severe illness from flu hospitalizations, and so on. It seems that our supply is somehow not keeping up. But hopefully that will resolve itself very soon, and it should not stop you from seeking it out if you are someone at high risk of doing poorly from the flu. We do have antiviral treatments. The sooner the better to start with them, and so it's great to have a plan for flu, just like we want to have for COVID, a plan before you catch it. And so by way of COVID update, as I've mentioned, a lot of the data sources that we use, especially for cases and wastewater, haven't been updated in more than a week, probably because of the holiday. So I'll touch on what we are seeing overall and what we think we can expect next. So I'll start with the variant proportions. This was updated on December 24th, and you can see in this lilac color here, the XBB is gaining ground actually pretty quickly here. And so it now makes up about 18% of overall cases. Last week it was at about 11%. So it seems to be gaining ground fairly quickly. And there's definitely some regional differences with it. And so you can see that in the Northeast, remember it's this lilac color, it is accounting for more than 50% of cases in the Northeast area. Here in California, well, it's not even reporting on our state of California website as of December 21st. It's not saying anything about XBB, but in the region 9 that you can see includes a lot more than just California. It's at about 8.5%, so significantly less than in the Northeast region. What do we know about it? What does it mean? It's getting really difficult to say. We do see that in the state of New York, hospitalizations are certainly increasing steadily, really since mid-November. Is that because of XBB being over 50% in that region too, or New York is? Really difficult to say. There's just so many variables like vaccination and booster status and the different variants and underlying conditions and everything like that. So very, very difficult to tie one thing to another. But what we do know from laboratory analysis is that XBB is not neutralized by our monoclonal antibodies. Neither is the BQ1 and the BQ.1.1, the others that we're mostly contending with. And so we know that that's one less tool that we can rely on. And unfortunately, XBB, like the BQs, is in that category of variants that we don't seem to be able to fight with our prior immunity from earlier Omicron strains. And so it's just something that we'll have to keep learning about. And I learned last week on the state of California call that there have been 40 instances of a variant called CH.1.1 that they've discovered on genomic sequencing. And of course, I took note of this because I wasn't too happy to hear that we're on to the C's from all of the B's. So this is still an Omicron subvariant, but it's called CH.1.1. And that has been detected here in the state of California. On December 22nd, the European CDC added CH.1.1 as a variant under monitoring. And this is a sublineage that we've been seeing in other parts of the world, namely Austria, Germany, and India have all indicated that they're seeing it. So far in the analyses that have been done, there is a mutation there that people aren't liking. It's the P681R mutation. And this mutation seems to be kind of enhancing the virus's ability to latch onto our cells. And it seems to be, it's a mutation that was in the Delta. So there was definitely concern from some prior studies that that was the mutation that made Delta particularly virulent, made folks sick, basically made it more fit when it was compared to the Alpha variant that came before it. So this is a mutation on the spike that, you know, doesn't seem like we like very much. And it is on the CH.1.1. Now, will that variant, you know, make a big dent over here? We're not really sure. It just depends how it gets along with the other variants. So it'll just remain to be seen, but something that we can take note of. As far as deaths in the United States from COVID, we're still kind of around 375 a day. So this isn't a great place to be, particularly as we are heading into deeper into the winter, and we've got the holiday mixing that we know just occurred. And so we do expect to see increasing cases from that, as well as the New Year's holiday that's coming up. And so we know that will be increasing. In fact, the CDC's own forecasting is showing an increase that looks fairly substantial. Of course, there's a pretty wide range there. So, but you can see that the expectation is that we go from this, you know, about 2,000 deaths per week up to about 4,000 deaths per week, so double by mid-January. And these are the CDC's own predictions. And there's a big range there. It goes all the way up to over 6,000 deaths per week. So it's hard to know where it's going to land, but as you can see, it looks like the CDC is predicting that it will go up. I think pretty much all of the modeling is predicting definitely cases will go up. But what about severity? What about hospitalizations? What about deaths? There's a lot of factors that are involved with it. So there's a lot of different scenarios that you can kind of play out. But there are definitely some concerns that I think that we need to have. And remember, these are just estimates. They're not going to necessarily take into account, let's say, if like what happened last year at Thanksgiving was to happen again, where we had Omicron just pop up on us, you know, will that happen again? It's hard to say. I reported last week on the outbreak that is happening in China. So if you're interested, check out last week's briefing. I went into a little bit more detail about the modeling and things of that nature. It's still really difficult to get a real handle on what's going on there. Some of the anecdotal reports certainly do look concerning. We know that they've dropped much of their mitigations, including they recently dropped requiring travelers that are inbound into China. They no longer have to quarantine. That's going to be starting January 8th. So they really are rolling back a lot of their mitigations. And so we are already seeing increasing cases, and we just don't know what that all is going to mean for the state of the pandemic, but it's something that we definitely need to be keeping an eye on. I know that India reported that they're starting to require travelers coming from China and a few other countries in Asia, requiring them to test negative before entering the country. We've not done anything like that in the United States for quite some time now, but just interesting to note that, other countries are taking note and they're doing their own strategies still. And so as it relates to the community levels, we can see that in California and in the Bay Area, quite a big portion of our region is in the high transmission zone. So that's not looking great right there in the middle of California. We just have a large area that's high, a lot of adjacent areas that are in the high transmission zone. So that is definitely not reassuring. And what does it mean? Well, I don't know what it's going to mean. I hope it means that we respond accordingly. I want to give a definite shout out to my city of Oakland, who reinstated mask requirements last week. Masks are now required for everyone 6 and up inside city buildings. This includes the library, the senior centers, the adult care facilities, the rec centers, and the civic center buildings. It was dropped right after Thanksgiving, and it was resumed not long after. So I just really want to appreciate all of the advocates and all of our local leaders that reversed that pretty quickly, hopefully before too much damage was done. I know a lot of city workers are breathing a sigh of relief. A lot of folks that utilize these facilities or want to utilize them, but maybe won't if there aren't masks required, are certainly pleased about this. And it's hard to believe that they weren't being required in senior centers and adult care facilities, but fortunately they are back for the foreseeable future, at least through March. So we are definitely appreciative that this will help to mitigate the impact and the amount of surge that we see this winter. So every bit will help. I am very hopeful that Oakland Unified School District will follow suit. I think that would be more than prudent, especially returning from the winter break when we know that there will be higher cases. And I'm going to talk a little bit more about this in a moment. Sacramento County entered into the high range, and one of their school districts, Sacramento City Unified School District, requires indoor masking after the community levels enter high. So they will likely be masking when they come back from their break. I haven't heard of other school districts doing this, but this seems like the way. If we've got high community transmission, then seems like a good time to put on masks, especially in schools, because we know that schools drive transmission. So hoping Oakland Unified is listening and other school districts as well. And how do we know that schools drive transmission? Well, I think we've all known this. Anybody who's had children, who's worked in a school, knows anybody in school knows that every winter we get ready for flu season. Every winter we get ready for colds. We know that when kids, go to school, they spread germs around. This is just how it is. We know this. So I don't think anyone ever was under an illusion, even though maybe we wanted to believe, but I don't think anyone should have been under the illusion that schools aren't sources of COVID transmission. I know I've said it repeatedly here. Anytime we have mixing, we're going to have an increased opportunity for transmission. And schools are a place of quite a bit of mixing. But we know that this got very politicized. We understand that there's reasons why children need to go to school, but we can hold those reasons at the same time that we acknowledge the fact that there can be transmission, and that there has been transmission, and that there have been outbreaks, and that there have been students who get COVID and bring it home, and so on. But there was a recent study, and it is a preprint, so it's not been peer-reviewed yet, but it looked at the role of different age groups in propagating Omicron in France. And what they did was try to establish the relative risk of different age groups in driving spread. So they measured the change in each group's proportion among all cases that got admitted to the ICU for COVID before, versus after the peak of each wave. And they looked at a few Omicron waves. And what they found is that children aged 10 to 19 years of age played the greatest relative role in propagating Omicron spread, especially when schools were open. So 10 years old to 19 years old, greatest role in propagating Omicron spread. And then this was followed by children 0 to 9, and then followed by adults aged 20 to 29. So this does not come as any surprise to me. I don't know a lot about how the France school systems work, but I know that here in the United States, my biggest concern has been the middle schools and the high schools where they move classes every hour. And for those who've been watching for a while, you know that I was really hoping that we were going to be cohorting students so that if someone got COVID, you could actually trace it and do an outbreak investigation and all of that. But all of that never really materialized. And so you have students mixing with everyone in the school. Every hour, a new class, a new set of people. I thought the teacher should move and the students should stay in the class, but that clearly didn't happen. And pretty much most of the isolation and quarantine has also gone by the wayside. We heard early on 6 feet is good for everybody, but 3 feet is good for students. So we knew that these were not necessarily things that were based in our knowledge about virus transmission. These were about us wanting to get children back to school. So again, it's okay to try to do both. And it's not too late. So I really hope that we'll see some changes here. But what they found in France was that the 10 to 19-year-olds played the greatest role in driving the waves, especially when schools are open, followed by 0 to 9 years old. So what does that tell us? It tells us that we first need to come to grips with this fact, if we have not already. I don't think any of us really believe that there was some kind of imaginary force field around the schools that kept COVID from spreading around and kept people from bringing COVID home. That's just ridiculous. But now we actually have documented proof. You can check out the preprint. The link is in the post, and you can even sign up to get updates for after it's fully peer reviewed, so we can follow that if that is of interest. But again, no big shockers there, no big surprises, but for those who need a proof, there it is. And so for me, this really underscores the need for us to be responding to the information that we have. And that means that when students come back from winter break, well, first of all, you all know I want to see the winter break extended by a couple of weeks so that all that holiday mixing and whatnot can be fully isolated, quarantine before y'all go back to school. But since that's probably not happening, the least we could do is test and mask when we come back to school. And of course, we know the most important interventions that we can do in our schools are improving the indoor air quality, the ventilation. It's a little cold to be keeping the windows open right now, so that is a problem. So not all schools are created equal. Not all schools have a great HVAC system. Some are relying on smaller units. And those, there needs to be enough of them. They need to be on in order to work. And so we need to make sure that the indoor air quality is sufficient, especially now during winter. But a KN95, a KF94, or an N95 mask on your child, on your student, is really the best way to go, at least until we get through this winter surge. Please, this is really going to help not propagate the spread. It will help reduce how high that surge goes, and it will surely spare vulnerable people who our little ones may be going around. This includes not only teachers, educators, but also parents, grandparents, and so on. So let's please be mindful. Let's encourage our school sites to be mindful. Why aren't we giving away KN95s at the door for everyone and encouraging and normalizing their use? That is just the bare minimum, I think, right now. So hopefully we can be mindful of that as school goes back into session. So what to expect next? Well, first, we don't know, AKA we're in a pandemic. So if it was an an endemic situation, we would be able to predict it with relative certainty what we're up for. But we frankly don't know. I think we are still in the situation where we can predict out, just like you saw in the CDC's modeling, we can predict out, maybe a few weeks, a month. But we don't really know how big that wave is going to get, how devastating it's going to be, what variants will be predominantly driving it, what will be the reason for most of the hospitalizations and deaths, or the amount, or which age groups are going to affect the most, because we haven't been able to predict it so far. In fact, in these last few increases, the 0 to 17-year-olds had the biggest increases in hospitalizations during some periods of time. So we don't know. We can't predict it. And that is why we still say that we're in a pandemic. We also don't know when the next surge is going to be after that, or if it's going to get better or not in the near future. So I think there's some things that we can be grateful for and hopeful for as well. So I think in good news, unlike last year, we do have much better access to treatment. We have Paxlovid in particular, which are the pills. We also have another option for folks who for some reason cannot take Paxlovid, and that is remdesivir, the 3-day IV treatment. And these, for anyone who is at risk of a bad outcome, please have a plan to get one of these treatments. It could save you or your loved ones. So we don't want to lose any more people. And anyone that does die from SARS-CoV-2 at this point, we need to be asking questions. Did they receive outpatient treatment is the number one question. And I think the sort of by way of the not so good news, we did lose a tool again this year. We lost Regeneron last year around this time. This year, we've lost our bebtelovimab, our monoclonal antibody, so that is unfortunate. Also, the Evusheld is not looking like it's providing much protection, although it's still being administered. It hasn't lost its authorization yet, I think simply because we don't have another alternative for people who are immunocompromised to protect themselves. But it doesn't look like it has much activity against what is circulating now. Will it work for something that pops up in a few months? Maybe. We don't really know. And so I think it's not dangerous to administer it. It just may be of marginal benefit, and people should certainly know that. The other concerning news is what I mentioned about what is happening in China. When you have as many cases as what it appears is happening there now, every time you have this much transmission, we know that that's an opportunity for new variants to arise, and variants that may get around our prior immunity. So this is definitely something we need to be keeping an eye on and being concerned about, especially with so much worldwide travel that's going on. It really only takes a plane ride before we bring over a new variant that could take hold in a given area. So we just don't know. We cannot see the future. Unfortunately, still, we are still in an active pandemic. I think the other thing that is not so good news for us this year compared to last year is that we don't have as many mitigations in place. Many people aren't wearing masks. Masks aren't required on public transportation. They're not required in the schools. They were this time last year. So that's probably the thing that's bringing me the most concern right now, is that we had masks last year and we still got hit so hard. We didn't even know what hit us, as many cases and as many deaths as we had in the Omicron surge last year. So this year, as we head into our winter surge, with sort of an unknown situation happening in other parts of the world, with people not wearing masks in the key locations where we know that they're needed, this is what worries me the most. But guess what? We can wear masks. There's no requirement that we don't wear masks. So I think this is the way that we should be thinking about it, especially right now. I am seeing more people wearing masks right now. I think people realize that it's not just COVID. It is flu, it's RSV, it's Strep A. So might as well go ahead and protect ourselves from all the respiratory pathogens, and particularly with a high quality filtration type of mask as we contend with this winter surge. And just a reminder about getting boosted. Most people are not boosted. Most people, even in the older age groups, have still not received the Omicron booster. Last week, I went in some detail about the effectiveness of the Omicron booster based on two morbidity and mortality weekly releases that had come out. So if you're interested in that, check out last week's briefing. This week, I'm just going to provide a reminder about the Novavax vaccine. Novavax is a protein subunit vaccine. It's kind of the old school type of technology for those who didn't want to get the mRNA vaccine, or even if right now you can't or won't get an mRNA booster, you can request the Novavax vaccine. So please inquire about it. If you have loved ones who just weren't feeling the mRNA, talk to them about Novavax. This is an option that so many people still don't know about. I'm a little frustrated that people don't know about it. It's just not being really promoted at all, and that is frustrating. But it does look to be providing excellent coverage. I really am waiting for more information, more head-to-heads and things like that. We don't have a lot of that, but it is 2 doses, 3 to 8 weeks apart. You can err a little bit on the longer side if you like. That might even give better protection. And that is available for anyone 12 and up. So if you are not up to date on boosters and you won't get an mRNA booster, you can get a Novavax. If you haven't gotten any vaccines, you can get a Novavax. Please ask for it. We are administering at Roots, and we celebrate every time we administer one because we know that that is someone who wasn't going to otherwise get vaccinated. They like this old school technology, and we were able to talk to someone about it, and they agreed to go forward with it. So we do celebrate every time we administer a Novavax vaccine. So please ask about it. And last, we know that folks are going into, we're heading into New Year's. There's going to be celebrations. There's going to be parties. Please do so carefully. We know that one COVID infection can lead to a bad outcome. It can lead to post-COVID or long COVID. We also know that repeat infection has a cumulative adverse effect. I went over this in detail in a prior briefing. The link to that one is in the post if you want to learn more about the harms, the cumulative harms of repeat infection, and why even if you got it twice and did fine, we don't want you to get it a third time. We got it 3 times, we don't want you to get it a 4th time. We just don't know the burden, but what we do know so far is not reassuring for repeat COVID infections. So we want to try to avoid it. And so if you are planning on gathering during New Year's, we really hope that you will use a layered strategy to reduce the likelihood that your event is a super spreader, or the likelihood that you catch COVID or something else, and the likelihood that you pass it on to someone else. So there's so many places where we can do better, so many places where we can intervene with a strategy that will help reduce risks. So we want you to do as many or all of them as possible, especially given the time of year that we're in and all the things that I've just mentioned. So don't forget to get your 4 free tests from the government. You can order those. Just have them on hand, especially as we get into the winter surge. You can also come get them from your local community health center, including Roots Community Health Center. Make sure that you have enough rapid tests, and you usually need to do a couple or a few to make sure that it's accurate, because we know it doesn't turn positive as quickly as the PCR, but you can also use them pre-event. It's one layer of protection that if everyone is negative, at least you know that someone doesn't have a high amount of virus in their nose and doesn't have as high a likelihood of spreading it. We know it still can happen. That's why we want to do other things like improving our indoor ventilation. That could mean keeping your HVAC running, keeping HEPA filters going, opening up windows, and gathering outside as much as possible. Get your fire pits, get your heating towers, get all that stuff. You can make it comfortable to gather outdoors as much as possible. If you are going to go indoors, of course, you can wear a mask, but don't linger too long inside. Try to spend more of your time outside if possible. And if you are going to be in a place that you know is higher risk, let's say airports, airplanes, or other crowded indoor settings where you haven't had testing and you don't know the status of other folks in there, you can assume that there are people with COVID in your midst. So there you are going to want to wear a high filtration mask, an N95, a KN95, or a KF94. And so we all have to do our individual risk benefit assessments with everything we're doing. But if you do decide to go ahead and take risks, how about don't go around anyone high risk afterwards? Get 2 or 3 negative rapids after you've done something high risk before you go around anyone. And that's over about a span of a week to be on the safe side. And if you really do need to go around others, go ahead and wear the high quality filtration mask for source control so that you don't have to spread it around to anyone else. And if you are going to be gathering with others, please know how to get a hold of each other. This can become really chaotic if you don't know how to reach people and someone catches it. We want to let each other know. Let's create that culture of caring enough about one another that we will tell each other so we can stop the spread. And also for those who need to be treated so that they can get timely treatment. Remember, there's only a very small window in which to get treated. So the sooner people know they were exposed, the sooner they can go confirm that, in this case with a PCR test as soon as possible, because that will turn positive sooner, so that you can go ahead and get on those antiviral treatments. Once again, Paxlovid is choice number 1 for the vast majority of people. But remember, remdesivir, it goes down to even our newborns. So for our high-risk little ones who should be treated, again, we need a plan for them. And these need to be started within 5 days for Paxlovid, within 7 days for remdesivir. And our last choice is molnupiravir. It's not great, but if you can't have the other 2 for some reason, like severe kidney disease or something like that, then this still does remain an option. So we absolutely want to make sure that folks who are high risk of a bad outcome get treated. We're stocking up on masks and tests. We're knowing where, when, and for what to get tested. We're getting up to date on all the vaccines, COVID, flu, anything else you might be behind on or your children might be behind on. We want to make sure to do everything we can to avoid initial infections and repeat infections. And of course, we want you to maintain a balanced diet, get some exercise, manage your stress levels, consider a multivitamin supplement with additional vitamin D, and get a good night's sleep. We are going to take next week off, and we will see you the following Tuesday at 10 a.m. See you then.